There is a conversation I have been wanting to have with you for a long time, not the kind of conversation that happens in a clinic, where time is short and the agenda is fixed, and both of us are aware that there are other patients waiting. Not the kind of conversation that gets rushed through in 15 minutes between a blood pressure reading and a prescription refill, but a real conversation, an honest one. The kind where I can sit across from you and speak plainly about something that matters enormously, and that doesn't get nearly enough of the attention it deserves. I want to talk to you about what happens when your heart is in trouble and there is no one else around. I have been a cardiologist for more than 20 years. In that time, I have treated thousands of patients, attended hundreds of emergencies, and stood at the bedsides of people whose outcomes were decided not in the hospital, but in the minutes before they arrived. And what I have learned, more than almost anything else, is that the gap between surviving a cardiac event and not surviving one is rarely about the quality of the care that follows. It is almost always about the speed of the response that precedes it. What you do in the first 5 minutes of a heart attack matters more than almost anything that happens afterward. And yet, despite everything we know as a medical community, despite all the public health campaigns and the awareness initiatives and the articles and the television segments, people are still waiting. They are still sitting in quiet houses with pressure building in their chests, telling themselves it is probably nothing. It will probably pass. They do not want to make a fuss. They will give it another few minutes and see how they feel. And some of them do not get another few minutes. I am here today because I refuse to accept that this is inevitable. I am here because the knowledge that can change this outcome is not complicated or technical or reserved for medical professionals. It is straightforward. It is learnable. And it is something that every person over the age of 60 who spends any amount of time alone should carry with them the way they carry their house keys. So let's begin. And I mean really begin, not with a list of symptoms, not with a set of bullet points, but with an understanding of why this knowledge is so urgent, so personal, and so necessary. Think about a typical day in your life. You wake up in the morning. Perhaps your partner is there. Perhaps they're not. Perhaps you live alone. Perhaps your children live across town or across the country. Perhaps your closest neighbor is not as close as you'd like. You go through your morning routine. You have breakfast. You do whatever you do, read the paper, tend the garden, run errands, meet a friend, watch something on television. Hours pass. And during those hours, there may be long stretches when you are simply, quietly, completely by yourself. Most of those moments are peaceful. Most of them pass without incident. But any one of them could be the moment when your heart, after years of faithful service, begins to struggle. And in that moment, what you know and what you do will determine what happens next. This is not meant to frighten you. I am not interested in fear as a motivator. Fear fades. Fear makes people anxious without making them prepare. What I am interested in is equipping you. Arming you with understanding so complete and so clear that if that moment ever comes, you will not freeze. You will not hesitate. You will not waste the time that your heart cannot afford to lose. Let me start with something that I think is genuinely underappreciated, even by people who consider themselves health conscious and well-informed. The heart is not an invincible organ. It is not a machine that runs forever without complication. It is a muscle, roughly the size of your fist, weighing less than a pound, and like all muscles, it requires a constant, uninterrupted supply of oxygen-rich blood to function. That blood is delivered through a network of coronary arteries, and the health of those arteries determines in large part the health of your heart. Over a lifetime, these arteries can develop what physicians call atherosclerosis, a gradual accumulation of fatty deposits, cholesterol, calcium, and inflammatory cells that form plaques along the inner walls of the vessel. These plaques don't develop overnight. They grow slowly, over years and decades, often without producing any symptoms at all. Person can walk around for years with significant coronary artery disease and feel completely fine, because the narrowing hasn't yet become severe enough to cause symptoms during rest or even moderate activity. But plaques are not static. They are dynamic living structures, and some of them become unstable. When an unstable plaque ruptures, when its fibrous cap tears open, the body responds the way it always responds to a breach in a vessel wall. It sends platelets to the site. It activates the clotting cascade. It begins building a thrombus, a blood clot, to seal the rupture and stop what the body perceives as bleeding. In most parts of the body, this is a life-saving response. In a coronary artery, it can be catastrophic, because the clot that forms at the site of the ruptured plaque can grow large enough to partially or completely obstruct blood flow through the artery. And when blood flow is reduced or stopped, the segment of heart muscle that depends on that artery for oxygen begins to experience ischemia. It begins to starve, and if the obstruction is not relieved, that segment begins to die. This is the heart attack. This is the myocardial infarction. This is what all the urgency is about. And here is the fact that I want you to hold in your mind, because it is the most important thing I will say today. The damage that occurs during a heart attack is not fixed at the moment it begins. It is progressive. It unfolds over time. Heart muscle cells begin to die within 20 to 40 minutes of losing their blood supply. After 2 hours of complete occlusion, a substantial region of muscle may be permanently destroyed. After 6 hours, the infarction can be extensive. But if blood flow is restored quickly, if the clot is broken up and the artery is reopened, the damage can be dramatically limited. This is why cardiologists talk about time to treatment with such intensity. Every minute of delay is not a metaphor. It is a measurable quantity of heart muscle lost. And heart muscle, once lost, does not regenerate. The scar that forms in its place is not contractile tissue. It does not pump. It does not contribute to the heart's function. Your heart will adapt. It will compensate, but it will carry that scar forever. So when I tell you that what you do in the first 5 minutes matters more than almost anything else, I'm not being dramatic. I am being precise. Now, what does your body actually feel when this process begins? This is where I want to spend real time, because the answer is more nuanced and more variable than most people expect. And that variability is part of what makes heart attacks so dangerous. The classic presentation, the one embedded in our cultural consciousness through decades of film and television, is a sudden, severe, crushing pain in the chest. A man grabs his chest. His face contorts. He staggers. He falls. The scene is unmistakable and urgent and impossible to ignore, but clinical reality is considerably more complex than that. A significant proportion of heart attacks, particularly in older adults, in women, and in people with diabetes, begin with symptoms that are subtle, ambiguous, and easy to attribute to something less serious. The heaviness in the chest that feels like it might be yesterday's dinner. The shortness of breath that seems like perhaps you're just not as fit as you used to be. The jaw ache that you've been half blaming on your dentist appointment 2 weeks ago. Fatigue so profound and so different from ordinary tiredness that it stops you in your tracks, but that you talk yourself out of worrying about because you've been tired before and it always passed. These quiet presentations are not less dangerous than the dramatic ones. In many ways, they are more dangerous, precisely because they are easier to rationalize away. And rationalization in this context is a luxury that your heart cannot afford. Let me walk you through the full spectrum of symptoms, in the detail that I think they deserve, so that you can recognize them in yourself without second guessing. The chest discomfort itself is the most common and most important symptom, but I want to be careful about how I describe it, because the word pain is misleading for many patients. A significant number of people having heart attacks describe what they experience not as pain but as pressure, tightness, heaviness, squeezing, or fullness. Some describe it as a band across the chest. Some say it feels like something sitting on them. Some say it is more of an awareness than a sensation, an uncomfortable, insistent wrongness in the center of their chest that they cannot locate precisely and cannot make better by changing position. It is typically located in the center or left side of the chest, though it can be felt more diffusely. It may or may not radiate. The radiation pattern that most people know is into the left arm, a heaviness or aching or numbness that moves from the shoulder down into the arm, and sometimes into the hand and fingers. But radiation into the right arm is also documented. Radiation into the jaw is extremely common and frequently missed. Patients describe a dull, persistent aching under the lower jaw, sometimes on both sides, that they mistake for dental pain or tension in the neck muscles. Radiation into the back, particularly between the shoulder blades, is seen especially in women and in older patients. Radiation into the upper abdomen or the region just below the sternum, the epigastric area, can mimic severe indigestion or a stomach ulcer with remarkable fidelity. The chest discomfort may be constant, or it may come in waves. It may be present continuously for 20 minutes or more, which is one of the clinical criteria that distinguishes a heart attack from angina. It may vary in intensity. It does not typically improve with antacids, which is one useful differentiating point when a patient is trying to decide whether what they're experiencing is cardiac or gastrointestinal in origin. Shortness of breath deserves particular emphasis because it is both common and frequently overlooked as a cardiac symptom. You may notice that you cannot get a satisfying breath, that each inhalation feels incomplete, as if the air is not going all the way in. Some patients describe an oppressive sensation in the chest that makes expansion feel restricted. Others describe a subtle air hunger, a sense that something about their breathing is off without being able to articulate precisely what. This symptom can appear before any chest discomfort begins, alongside it, or in isolation, and in any of these contexts it should be taken seriously, particularly if there is no obvious explanation such as physical exertion, asthma, or a known respiratory condition. The diaphoresis, the cold, clammy sweat that accompanies many heart attacks, is distinctive in character. It is not the warm, gradual perspiration of physical activity. It breaks out suddenly and without warning. The skin may feel cool and moist simultaneously. The sweat may be profuse, or it may be subtle, damp palms, a cool forehead, an overall sense of clammy discomfort. Mechanism is autonomic, your nervous system responding to cardiovascular distress by activating sweat glands as part of a broader stress response. When this symptom appears alongside anything on this list, it significantly increases the probability that something cardiac is happening. Nausea, with or without vomiting, is present in a meaningful proportion of cardiac events, particularly in women and in older adults. The nausea may be mild and persistent, or it may be sudden and severe. Some patients vomit repeatedly and spend valuable time attributing their symptoms to food poisoning or a stomach virus before recognizing that something more serious is happening. The cardiac origin of this nausea is partly neurological. The vagus nerve has extensive connections to both the heart and the gastrointestinal system, and cardiac distress can trigger GI symptoms through this pathway. Lightheadedness, or syncope, or actual loss of consciousness can occur when the heart's pumping efficiency is reduced to the point where cerebral perfusion, blood flow to the brain, is compromised. Some patients describe a graying or darkening at the edges of their visual field. Others feel a floating, disconnected sensation. Others feel as if they are about to faint without actually losing consciousness. Any of these symptoms in the context of chest discomfort or shortness of breath should be treated as a serious warning. And then there is the fatigue, not ordinary fatigue, not the tired you feel after a long day or a poor night's sleep. The fatigue that can accompany a cardiac event is of a different quality entirely. A profound, sudden heaviness of the entire body, a sense of the limbs becoming heavy, a feeling that even the act of sitting upright requires more energy than you have. Some patients describe it as feeling like they are moving through water. Others say they felt as if all the strength had simply left their body at once. This symptom is particularly important in older adults and in women, in whom it may be the most prominent feature of the event. I also want to mention what some patients and some medical texts describe as a sense of impending doom. It sounds dramatic and vague, but I have heard it too many times across too many patients to dismiss it. A deep internal certainty that something is terribly wrong. Not a specific location, not a specific symptom, just a knowledge somewhere beneath conscious thought that the body is in serious trouble. If you ever feel this, especially in conjunction with any of the physical symptoms I have described, please trust it. Your body's intelligence runs deeper than your rational mind. Now, you have recognized that something is wrong. What do? You call for emergency help. Right now. Not after another few minutes. Not after you call your son or your daughter. Not after you check the internet to see if your symptoms match a heart attack. Right now. I want to spend some time on this because the decision to call and the speed with which it is made is one of the most consequential decisions of this entire situation. Research into cardiac outcomes consistently shows that one of the most significant predictors of survival is the time between symptom onset and the initiation of definitive treatment, opening the blocked artery through angioplasty or thrombolysis. That time is composed of several intervals, and the very first one, the time between when symptoms begin and when the patient calls for help, is often the longest and almost entirely within the patient's control. Studies have documented that patients wait, on average, anywhere from 2 to 4 hours after the onset of symptoms before calling emergency services. 2 to 4 hours, during which the ischemic cascade is progressing, during which heart muscle is dying, during which the window for the most effective interventions is narrowing. The reasons for this delay are almost always psychological. Uncertainty, I'm not sure enough that something is wrong to justify calling. Minimization, it's probably nothing serious, I don't want to overreact. Social concern, I don't want to worry anyone, I don't want to be a burden. Logistical hesitation, let me see if I can drive myself. Let me wait until my neighbor is home. And a deep, almost visceral resistance to confronting the possibility that something this serious might actually be happening. I understand all of these reactions. They are human. They make complete psychological sense. In the context of a cardiac emergency, each of them represents minutes of delay, and minutes of delay represent permanent loss. So I want to offer you a reframe. Instead of asking yourself, am I sure enough to call for help? Ask yourself, am I sure enough not to call? Because the cost of calling when you didn't need to is a few hours of your time and perhaps some embarrassment. The cost of not calling when you did need to may be your life. Framed that way, the decision becomes much simpler. Call your emergency number. In most countries, this is 911 or 112 or 999. Know your number before you need it. When the dispatcher answers, give your address first. Your complete address. The street number, the street name, the apartment number if relevant, the city. Give this before your name, before your symptoms, before anything else. Because if your call drops, and calls do drop, they need to know where to send help. Then tell them you believe you may be having a heart attack. Tell them you are alone. Tell them if your front door is locked or if there are any access issues. And then stop talking so much and start listening. Let the dispatcher guide you. Answer their questions. Follow their instructions. And do not hang up. The dispatcher is not simply a person who transfers your call. They are a trained professional who is already coordinating the response while speaking with you. They are relaying your information to paramedics who are already moving in your direction. They are prepared to provide real-time guidance, to coach you through this, to stay with you for every second until help arrives. That voice on the other end of the line is one of the most valuable resources you have in this moment. Use it. Do not attempt to drive yourself to the hospital. I want to say this as clearly and as firmly as I can, because it is a choice that people make, people who are trying to be practical, trying to be efficient, trying to avoid the drama of an ambulance. And it is one of the most dangerous choices possible in this situation. A heart attack can escalate without any warning. Consciousness can be lost within seconds. Cardiac arrhythmia, an abnormal heart rhythm, can develop in an instant and impair your ability to control a vehicle before you even register that anything has changed. If you are driving when this happens, you are not only risking your own life, you are risking the lives of everyone near you on that road. And even if you remain conscious throughout, the physical effort of driving, the stress, the concentration, the movement, places additional demand on a heart that is already in crisis. The ambulance brings the hospital to you. It brings trained paramedics who can monitor your rhythm, administer medications, start intravenous access, and perform defibrillation if needed, all before you reach the hospital doors. It brings equipment that can keep you alive if your heart loses its normal rhythm during transport. These are not luxuries. They are often the things that determine whether you survive the journey, stay where you are, call for help, let help come to you. Now, while you're on that call or immediately after placing it, there is one more action to take, and it is one of the most evidence-based interventions available to you without medical equipment. Take an aspirin. Let me explain this with the precision it deserves. A standard regular aspirin, not enteric-coated, not extended release, in a dose of 325 milligrams if available, though 81 milligrams also provides meaningful benefit. And the instruction is to chew it, not swallow it whole. This is not a minor detail. When you chew aspirin, it is broken down immediately into fine particles that are rapidly absorbed through the mucous membranes of your mouth and the gastric mucosa. This gets the active compound into your bloodstream significantly faster than swallowing an intact tablet, which must first dissolve in the stomach acid before absorption can begin. Aspirin's mechanism of action in this context is the inhibition of platelet aggregation. Platelets are the blood cells primarily responsible for clot formation. Aspirin irreversibly binds to an enzyme called cyclooxygenase 1 within platelet cells, blocking the production of thromboxane A2, a substance that promotes platelet clumping and clot expansion. By doing this, aspirin slows the growth of the thrombus that is obstructing your coronary artery. It does not dissolve the existing clot, but it impairs the clot's ability to expand further, and in the critical minutes before definitive treatment, that difference in clot size can correspond to a meaningful difference in the amount of heart muscle that is saved. This intervention is so well established that it is part of the standard emergency response protocol in essentially every developed healthcare system in the world. When paramedics arrive, one of the first things they confirm is whether you have taken aspirin. If you have already done so, you have already initiated one of the key components of acute cardiac care. If you have not, they will give it to you immediately. The contraindications are specific and relatively uncommon. A true aspirin allergy, not sensitivity, not intolerance, but a genuine allergic reaction involving hives, angioedema, or anaphylaxis, is a contraindication. Certain medications that your doctor has specifically told you not to combine with aspirin may also apply. If you are unsure whether this applies to you, take the aspirin and tell the paramedics what you took when they arrive. They can make the clinical assessment from there. For everyone else, which is the vast majority of adults over 60, one aspirin chewed at the onset of cardiac symptoms is one of the most powerful self-administered interventions in emergency medicine. Keep aspirin accessible. Not just in one place, in multiple places. Your nightstand for the moments when symptoms begin in the night. Your kitchen for the hours you spend there. Your living room for the hours you spend there. Your bag or pocket for when you're out. Expiration date checked twice a year. Regular aspirin not coated. This simple preparedness step costs almost nothing and could, quite literally, save your life. After you have made the call and taken the aspirin, I need you to do something that will feel counterintuitive. Something that goes against the instinct that most of us have when we are frightened and our bodies are behaving in ways we don't understand. I need you to stop moving. Sit down or lie down and stay there. Every physical action you take, walking across a room, carrying something from one place to another, climbing a stair, even standing for an extended period, requires your heart to pump more blood at a higher rate with greater force. Under normal circumstances, your heart meets these demands effortlessly. But during a heart attack, when blood supply to part of the cardiac muscle is reduced or absent, that increased demand cannot be met. You are asking an engine to run harder when it is already running on a fraction of its fuel. Physical activity during a heart attack doesn't just waste energy. It can directly worsen the outcome. Increased heart rate means more oxygen demand in a muscle that is already ischemic. Increased blood pressure means more afterload on a ventricle that is already struggling to contract normally. Physical exertion can trigger arrhythmias. It can accelerate the propagation of the infarction into surrounding tissue. The most protective thing you can do for your heart in those minutes is reduce its workload to the absolute minimum possible. And the way you do that is to stop, sit, and be still. Find a supported position. Sit with your back against something firm, the back of a sofa, an armchair, a wall. Let your feet rest flat on the floor. Let your hands rest in your lap or at your sides. If you feel faint or dizzy, lower yourself carefully to the floor or onto a bed and lie on your side with your head slightly elevated. Do not lie flat on your back if you can avoid it, because this position can compromise your breathing and increase the feeling of pressure in the chest. Once you are positioned, do not get up again unless there is an immediate safety reason to do so. Everything else, feeding the cat, turning off the stove, finding your wallet, putting on your shoes, calling someone to tell them what's happening, all of it can wait, or all of it is less important than your heart surviving the next 20 minutes. I have had patients tell me, after surviving their events, that they kept getting up to do things while waiting for the ambulance. One woman got up 3 times, once to make sure the front light was on, once to get a glass of water, once because she suddenly remembered she had left something on the hob. Each time she got up and sat back down, she felt worse. By the time the paramedics arrived, she was in far more distress than she needed to be. She survived, but her cardiologist was direct with her afterward. The exertion almost certainly extended the area of her infarction. Stay still. That is the instruction. Not mostly still. Not still except for the important things. Still. Now, if you have enough physical stability and you are close enough to your front door to reach it safely, there is one small action worth taking before you settle into complete stillness. Unlock your front door. This sounds almost too minor to mention alongside everything else we have discussed, but it has real practical importance. When paramedics arrive at a locked door, they face a decision: wait for someone with access, call for additional resources to force entry, or break in. Any of these options introduces delay, and even a small delay in the context of everything we have discussed about time and cardiac muscle is not trivial. If you can reach your door safely, unlock it. If walking to the door requires more exertion than you feel you can safely manage, do not attempt it. Your stillness is more valuable than the unlocked door. But if you can do it with minimal physical effort, do. And think about the longer-term version of this preparation. A key lockbox mounted outside your front door allows you to give the combination to a dispatcher over the phone, enabling paramedics to access a key without forcing entry. Smart locks can be remotely unlocked via an app on your phone or by giving the PIN to a dispatcher. These are simple, inexpensive solutions that cost you nothing to implement now, and that could matter enormously in a future emergency. While you are waiting, your phone remains your most important tool, and I want you to use it in a way that most people don't think about. Switch to speakerphone. Set the phone down beside you. Let the dispatcher's voice fill the room. This removes the physical strain of holding the phone, allows your arms to rest completely, and keeps you connected even if your strength diminishes. The dispatcher can hear your breathing, the sounds in the room, your voice, and they can relay real-time updates to the paramedics approaching your location. But there is something on your phone that may matter even more than the call itself, and that is your medical ID. Every modern smartphone has a feature that allows you to store critical medical information in a location that is accessible from the lock screen without requiring your passcode. On iPhone, it's accessible via the Emergency SOS feature in the Health app. On most Android devices, it can be found in Safety and Emergency settings. This information can be viewed by paramedics, nurses, and physicians the moment they pick up your phone before you have said a single word to them. Even if you are unconscious, fill in this information completely. Your full name, your date of birth, your blood type if you know it, every medical condition you have been diagnosed with, not just cardiac conditions, but everything. Every medication you currently take, with the dose and frequency. Every allergy you have, with particular emphasis on drug allergies, because treatment decisions in an emergency may hinge on knowing that you are allergic to penicillin, or to iodine contrast, or to a specific class of blood pressure medication. And at least 2 emergency contacts, their full names and phone numbers. If you have a pacemaker, note it. If you have an implanted cardioverter defibrillator, note it. If you take warfarin or another anticoagulant, note it, because this will immediately affect decisions about invasive procedures. If you are diabetic, note it, because blood glucose management is a critical part of cardiac care. If you have kidney disease, note it, because many of the medications and contrast agents used in cardiac procedures require dose adjustment in patients with reduced kidney function. None of this information is difficult to provide, but most people have never done it. And a paramedic who can read your complete medical history from your lock screen in the first 30 seconds of your care is a paramedic who can make faster, more accurate, safer decisions about your treatment. Set this up today. Not after you finish this video, not this weekend, not sometime this week. Today. It takes less time than you think, and it lasts indefinitely. And now I want to talk about breathing. I have deliberately placed this near the end, because I want it to be the thing that stays with you longest. The thing that you can carry with you everywhere at no cost, with no equipment, requiring no preparation beyond the practice of it. When a cardiac event begins, the fear is immediate and visceral. It is one of the most primal fears a human being can experience. The fear that the body itself is failing, that the machinery of life is breaking down, that the moment you have always known could come has arrived. That fear is completely understandable. It is human. It is not a weakness or a failure of composure, but it is also, physiologically speaking, dangerous. When the brain perceives extreme threat, the sympathetic nervous system initiates what is commonly called the fight or flight response. Adrenaline and cortisol surge through the bloodstream. The heart rate increases dramatically. Blood pressure rises. The muscles of the body tense in preparation for physical action. Respiratory rate increases. Blood is diverted from digestive organs toward muscles. Inflammatory markers rise. Clotting factors are activated. Under most circumstances, this response is adaptive. It prepares the body to respond to physical danger. In the context of a heart attack, each of these physiological changes is harmful. A dramatically elevated heart rate means dramatically increased oxygen demand in a cardiac muscle that is already ischemic. Elevated blood pressure increases the workload on the left ventricle at the moment when its function is most compromised. Increased clotting factor activity may actually promote further thrombus growth. The stress response, in this particular context, is working against you. Controlled breathing is the most accessible and most effective tool available to you for moderating this response. The technique I want you to use is sometimes called resonance frequency breathing, or extended exhale breathing, and it has been studied extensively in both healthy populations and in people with cardiovascular conditions. The practice is simple. Inhale slowly and fully through the nose for a count of 4 seconds. Allow the chest and abdomen to expand naturally. Hold the breath gently at the top for 1 or 2 seconds. Do not strain, just pause. Then exhale slowly and completely through the mouth for a count of 6 to 8 seconds. The exhale should feel like a slow, controlled release, not a forced expulsion. The key is in the ratio. The exhale is longer than the inhale. This asymmetry is not arbitrary. The extended exhale specifically activates the vagus nerve, the primary conduit of the parasympathetic nervous system, through a mechanism involving changes in intrathoracic pressure and the baroreceptors in the chest wall. The parasympathetic nervous system is the counterbalance to the fight or flight response. It promotes rest, slows the heart rate, reduces blood pressure, and activates the body's restorative functions. By breathing this way, you are not ignoring what is happening. You are not pretending that everything is fine. You are actively using a physiological mechanism to prevent your nervous system from compounding the crisis. You are keeping your heart rate from spiking further. You are supporting oxygen delivery to every tissue in your body. You are giving your heart the most stable possible environment to function in during the most unstable possible situation. And you are giving yourself something to do, something to focus on. In a moment of extreme helplessness, that focus is not trivial. Patients who have survived cardiac events and who had some kind of focal point during the waiting period consistently describe the experience as more manageable than those who had nothing to anchor to. Your breath is always there. It is always available. And when everything else feels out of control, it is the one thing that is completely yours. Practice this today, and tomorrow, and the day after. Not because you expect to need it soon, but because skills that are practiced regularly become reflexive. They return to the body under stress without requiring conscious retrieval. The person who has breathed this way thousands of times on quiet Tuesday mornings will find, in the moment of crisis, that their body knows how to return there. The person who has only heard about it will struggle to remember the instructions when their mind is flooded with fear. Make it a daily practice. 5 minutes in the morning. 5 minutes before sleep. It will improve your resting heart rate, your blood pressure variability, your sleep quality, and your capacity for calm. And it will be there for you if you ever need it in the way we have been talking about today. I want to spend a few more minutes with you before we close, because I feel there are things that need to be said that exist outside of the clinical framework we've been working within. We live in a society that has, in many ways, not done right by older adults when it comes to health education. The information that could prepare someone for a cardiac emergency is not complicated. It is not esoteric. It does not require medical training or advanced literacy or access to expensive resources. But it is not routinely given. It is not consistently taught in schools, or in community centers, or in the offices of general practitioners who have 15 minutes per patient and a list of problems to address that is longer than the time available to address them. And so people arrive at their 60s, their 70s, their 80s, having lived full and rich lives, having navigated extraordinary complexity in every other domain, raising children, managing careers, navigating loss, building relationships across decades, without ever having been given the basic information about what to do if their heart fails when they are alone. That is not a personal failing. That is a systemic gap. But it is one that you can close for yourself today, and one that you can close for the people you love by sharing what you have learned. I want to say something else, because it matters. The fear of being a burden is one of the most pervasive and most harmful forces in the healthcare experiences of older adults. I see it in my clinic constantly. Patients who waited to call because they didn't want to worry their children. Patients who tried to drive themselves because they didn't want to put anyone out. Patients who dismiss their symptoms for days because they didn't feel entitled to take up emergency resources over something that might be nothing. You are not a burden for seeking help when your heart is in trouble. You are not dramatic. You are not overreacting. You are not wasting anyone's time. The paramedics who respond to your call have chosen a profession built entirely around being there for people in exactly this moment. The dispatchers who take your call are trained for this. The physicians and nurses who will care for you are there because they want to be. Call them. Let them come. Let them do what they have prepared their entire professional lives to do. And you, in calling, in acting, in refusing to wait until you are absolutely certain, you are doing the most important thing. You are choosing yourself. You are saying, my life has value, my heart is worth fighting for, and I am not going to let embarrassment or uncertainty or the fear of being a fuss cost me the years I have ahead of me. Those years are real. The people who will be glad you survived are real. The mornings and the meals and the conversations and the small daily joys that constitute a life, those are real. They are worth fighting for. Even in a quiet house on an ordinary afternoon when you are the only one around to do the fighting. Let me bring together everything we have talked about today, not as a list to be memorized, but as a coherent, integrated approach to the most important emergency you may ever face alone. Know what your body is telling you. Learn the full language of cardiac symptoms, the pressure and the radiation, the breathlessness and the sweating, the nausea and the fatigue, and the profound sense of wrongness. Know that these symptoms may be subtle. Know that they may not match the dramatic version you have seen on television. And know that when they appear, particularly when 2 or 3 of them appear together, particularly when they feel different from anything you have experienced before, they deserve your immediate and complete attention. Call for help without hesitation. Give your address. Stay on the line. Do not drive. Do not wait for certainty. The cost of calling too early is nothing. The cost of calling too late is everything. Take aspirin immediately. Chew it. Keep it accessible. Know where it is. Make sure it hasn't expired. Stop all physical activity. Sit or lie in a supported, comfortable position. Do not exert yourself. Let your heart rest while help is on the way. Unlock your door if you safely can. Think about long-term solutions, lockboxes, smart locks, visible house numbers that reduce the barriers to emergency access. Use your phone wisely. Speakerphone while you wait. Medical ID filled in completely and kept current. Emergency contacts included. This information can speak for you when you cannot speak for yourself. Breathe with intention. 4 counts in, hold, 6 to 8 counts out. Over and over. Anchor yourself in that rhythm. Let it slow your heart rate, lower your stress response, keep your body as stable as possible while you wait for the people who are coming to help you. These things together form not a checklist but a coherent response to an emergency that millions of people face every year, and that many of them face utterly unprepared. You are now prepared. You have been given something today that has real, measurable value, not abstract value, not theoretical value, but the kind of value that can show up in the most concrete possible way on an ordinary afternoon when everything that matters hangs on what you know and what you do. Please do not let this knowledge sit. Do not consume it passively and move on. Engage with it. Think about whether your aspirin is accessible. Think about whether your medical ID is set up. Think about what position you would take and where in your home you would settle if symptoms began right now. Think about who in your life needs to hear what you have heard today. Share it with your partner if you have one. Share it with your parents if they are living. Share it with the friend who lives alone, the sibling with a cardiac history, the neighbor who mentioned chest tightness last month and brushed it off. You do not need to make it a heavy conversation. You can simply say, I learned some things today that I thought were worth passing on. That small act of sharing is an act of love. And the life it might one day save may be one that matters more to you than you can fully articulate right now. Thank you for being here today. Thank you for taking this seriously. Thank you for valuing your own life enough to spend this time preparing to protect it. Your heart has been faithful to you every day of your life. It has beaten for you without complaint, without rest, without recognition. It has carried you through everything you have ever experienced, every joy and every grief, every ordinary morning and every extraordinary moment. It deserves a partner who will fight for it when it needs help. That partner is you. And now you know how. Stay well, take care of each other, and please share this today.